Thank you very much, Fiona and Jan, for inviting me, and thank you, PHARMAC, for hosting this day. And thank you all for braving the weather and coming along. We're not sure if we're going to get home, but it's an adventure anyway. You know, I wasn't going to come to this seminar. I looked at the list of seminars. I was telling my colleagues last night at dinner, and I said, not that one, not that one. There was something in the title, Polypharmacy. It was like, ugh, don't want to go there. We know it's a bad thing. You know, we're all doing it, and we're doing it badly. And I just didn't want to engage with it until I was asked to speak at it. Then I got really interested and really quite fascinated. But I was reflecting, I'm doing a paper on teaching and learning in medicine through Otago. I can really recommend it. And there's lots of reflection on everything. And I was reflecting on why I didn't want to engage with polypharmacy. And I don't know about you, and I guess some of you are probably in my sort of age range maybe. A lot of our medical education was through criticism and humiliation. Ritual humiliation was the norm in Edinburgh, where I train. And I guess when I graduated, I was quite defensive and, you know, have gone through medicine being a little bit defensive, I guess, a bit scared of criticism and all the scrutiny that we're under. So I guess that's why I didn't really want to engage with a topic that was a little bit threatening, and it gets more threatening as we go along, as you'll see. But if no one else benefits from anything that I talk about today, at least one GP in the North Island will have looked at the topic and learned something. Most importantly, I think, and Ian's touched on this already, is that there is no judgment implicit in this, and that's really one of my take-home messages, is that we're all doing the best that we can with the situation that we're in. Nobody is trying to harm patients. Nobody is wanting patients to be burdened with anything more than they have already to deal with. So I've just got a little request for you. The last 4 slides, if you haven't looked at them already, would you mind not looking at them during the presentation? If you looked at them already, forget the answer to the question, okay? Because there's chocolate fish at stake. So these are my objectives, looking at what polypharmacy is, some of the many definitions. Is it a problem? And I'm really looking from the swampy lowland of general practice, the coalface of general practice, and also the day-to-day coalface of palliative care. I thank Ian and Fiona for giving the big picture, the overviews, the tools, the apps maybe even, the acronyms. I'm not very good at all of that. I'm really just a bread and butter day-to-day GP in the swampy lowland. I'd like to look at patients in general practice who are burdened with polypharmacy, and a case study from there, and then patients in palliative care, and a case study from there. And then I'd like to look at an approach, which is my approach, and it's a bit of a palliative approach, and see if that can be applied in both general practice and palliative care. So these are some definitions. I was glad to see that Ian didn't have any one particular definition. The concurrent use of several medications, I mean, that's most people over a certain age, isn't it? The administration of more medications than are clinically indicated. I think that's there's a little bit of a judgment there, isn't there? 5 or more medications regularly, 10 or more regularly. And then there's appropriate versus inappropriate, or good versus bad. Did you know that BPAC audited all your polypharmacy last year? Did you know that? Hands up everyone who knew that. No? I discovered this very recently when I became very interested in this topic. And I looked on the BPAC website, and I found that they'd done an audit of 2016 of all the patients in the practice that I'd prescribed for. And I'm going to show you my audit, and I'm a bit nervous about it. So this is very brave. So of 60 to 69-year-olds that I had prescribed for, 13% had 10 or more medications. And it gets worse. 28% of 70 to 79-year-olds that I had prescribed for had 10 or more, and 39% of the 80-plus-year-olds had 10 or more medications. They did also put another little column of how you compare with peers like you, and another little column of the national average. I haven't even dared to put those up. It's so shameful. However, I've got an excuse, but I'll come to that in a moment. They also did a little rundown of what your favorites were. These are my top 10 of people who've got polypharmacy. These are the top 10 that I'm prescribing. Well, I wasn't too worried because none of your awful ones are on there, I don't think, Ian. Paracetamol, I thought, fair enough, you know. Lots of people taking paracetamol. My little excuse, I'll come back to the little excuse, is I've joined this practice 2 years ago. The GP who owned it retired recently. He'd been there for 34 years. His patients had grown old with him, and a new GP came in and bought it, and then I joined her, and I'm working as a long-term locum there. So this is a very elderly population. They're on numerous medications. They've stayed alive. Thanks to themselves, the GP, the multiple medications. I don't know, but there's a very, very elderly population, lots in their 80s and 90s, and some over 100. And they're on long lists, as you can see. I'm probably that little blip on the Wanganui polypharmacy thing. So I've inherited a lot of these patients. So paracetamol, a lot of them have chronic pain. Omeprazole, yeah, a lot of them are on that. They're reflux, whatever. The statins, you know, these are 80-plus-year-olds on statins. I really find it difficult to know when to start and stop statins, but I'm learning as we go. And then good old Zopiclone. I don't know about you, but I tried very hard for quite a long time to get everybody off their Zopiclone. I failed miserably. We know it does them little good. We know it causes all kinds of problems, but try and part them from it. Really, really hard. Same with the other benzos. You know, I went through this whole deprescribing of benzos phase, and it was a nightmare, absolute nightmare. I gave up in the end. Then codeine and tramadol, I was surprised to see those there, but then again, this is an elderly GP population, and we're trying to stay away from the strong opiates for chronic pain, so what do? I don't like those drugs for pain, but there they are. Yeah. So is it a problem? Yeah, we've heard about what a problem it is. We know it is. I mean, there's the names of the medications. I mean, patients can't remember the names of the pills. And then there's the colors. It's the little pink ones or the big blue ones. And you know, when they come to see you, they don't bring them usually. And they expect you to know whether it's the little pink one or the big blue one. I haven't a clue. I don't see them. Every now and then I see them in a blister pack or out of the bottle. I was thinking it might be good to do a sabbatical in a pharmacy and just watch them being dispensed so I could get to know what was what. But they keep changing, don't they? But patients expect us to know that. I think our mana goes right down when we don't know what the pills look like. And then there's the manipulating to get them out of the package, whether it's blister packing or the childproof pack. By the way, there's a chocolate fish for whoever knows who invented the child safety cap. Wanganui people keep quiet. Don't look, no. A Wanganui hairdresser. This is true. He's still a hairdresser. In the 70s. He's an inventor and a hairdresser. I know it's an odd combination, but it's absolutely true. He's my hairdresser. I hear all about it. He told me so. It must be true. And he invented it, and he was too poor and not savvy enough at the time to get the patent, so someone else took it away. And it's the biggest regret of his life. But anyway, it's responsible for a lot of difficulty for older people getting into their medication packs. But he told me he was traveling to Canada once, and he was sitting on the plane, and next to him was a doctor. And they got talking, and just apropos of nothing in particular, the doctor said, you know who saved most lives in the world, I think? It's that person who invented the safety cap for medicine bottles. And Claudia was sitting there, he said, that was me. He says, I don't know, he says it true. And then there's the swallowing the medication. I mean, some patients swallow a small meal of pills, don't they? There's side effects, there's interactions, there's all sorts of confusion. There's falls, there's other accidents, probably motor vehicle accidents there too. Hospital admissions we've heard about, and death we think is more common in people who are on multiple medications for whatever reasons. I put child poisoning in there because in a previous incarnation I was in pediatrics, and I saw a lot of children who were poisoned by swallowing their parents' or grandparents' medication that was lying around, especially sleeping pills lying by the bed. I put cost at the bottom. I know it's not about cost, is it? Yes, it is, but there it is. I put it at the bottom. So, difficulty with drug names. This is my favourite little... I keep a little notebook and I write funnies down in it because it just cheers you up, you know, sometimes. You do need a bit of a giggle. Heaven forbid that there's an antibiotic that makes patients more argumentative than they already are. And then hospice is full of oxymorons and other kinds of morons. But patients love their Dom Perignon, you know. I'm sure it goes down better because they think it's called that. And then there's all the iterations of, I can hardly say the word, ibuprofen, ifrupropen, ifrobrupen, ibuprofen, idiprofen. Hopefully not today. And then floxamillion, I think that was Fluclox, I like that one too. And the old paradox, which is sort of gone, but it was fun while it lasted.
Do your patients want a subscription to the medicines?
A subscription, yes. Yes, good one. I'd love to hear your funnies and connection. You've probably got some. So I looked at 20 patients in general practice. I just went through 20 consecutive patients that I'd seen over a few days, and I looked to see, I chose 7 because that was sort of between 5 and 10 who were on 7 or more medications, and those were the diagnoses. And there are no surprises there at all, I don't think. And most of them had multiples of those. So you wouldn't be surprised by any of those, I don't think. And then I did the same thing in palliative care. I looked at 20 drug charts, just one after the other, alphabetical, who were on 7 or more. And you know what? They were the same people, the same diagnoses, but the palliative ones were just a little bit further along, and they had their metastatic cancers, some of them, or end stage, whatever they had. And the interesting thing is that now palliative care includes everybody who's in their last years of life. It's not just cancer. So that's end stage renal, heart disease, cardiovascular, respiratory. Yeah, so it wasn't surprising that they were a very similar population. And I was really interested in Ian's comments about how do you know that they're in the last days, weeks, months, years of life. I think prognosis is becoming really, really crucial. It's not taught in medical school. I ask the trainee interns, they don't learn anything about giving a prognosis, formulating it, or communicating it, that is. And in hospice, we're kind of bound to know about prognosis because we're generally looking after people in the last year of life. But how do you know it's the last year of life? What are the prognostic tools for that?
The best evidence is insurance tables. So you look at insurance tables and people at 85 with such and such a disease.
I'll have to add that to the repertoire. Yeah, that's a good one.
But you don't know if that's accurate or not. That's just what they do for your policies.
In Wanganui, we have... We take people under hospice care who are in their last year of life, and somebody has to decide what, you know, who that is, and it's never 100%. It's never, you know, it's often not accurate. But in the shorter term, we're trialing some prognostic tools that will help us look at who's in their last weeks or months of life. And there are quite a number of tools. We're trialing 3 at the moment, and we score everybody. And then when they die, we look back and see how accurate we were. And we think we're getting quite accurate with the last months of life. And we think we can get it even better down to weeks. So it's a bit of a taboo subject in medicine. I've asked a lot of colleagues in the Palliative Medicine Society. People are not very keen to do this, but I think throughout New Zealand, people are using the palliative performance scale, which is a bit like a Karnofsky scale of 0 to 100, according to what people can do. And they're using that a bit for as kind of functional prognosis. In Wanganui, we've got this other special funding stream for the last month. They get a free month of residential care if they've only got a month to live. So we have to be good at estimating a month. How do you do that? And nobody's been able to say to me in the DHB what the prognostic tool is for that. So we've had to work it out for ourselves. And we think we're okay because they audit us. If we get it wrong, if we're getting too many of these people a month's free care, then we get slapped over the wrist. So we have to be better at it. So it's a fascinating area, and I think it will come more to the fore in the future. Already it's being talked about a lot more, about how we give these prognoses, because for one thing, families are very global now. You know, there's an old lady dying in the hospice and the family are scattered, and they've got airline tickets and they've got jobs and they have to put the jobs on hold, they've got families, and they come over and they say, how long is it going to be? That's the million-dollar question. And so we have to be better at that. So that's a slight digression from the topic, but it relates. So I'd like to talk about a patient in general practice. So This is in the practice where I've been for 2 years, and I got to know this chap about 2 years ago. He'd been at the practice as a patient for a long time, having had a terrible accident in his 20s and become paraplegic. And he was, I think, in a little bit in the too hard basket. And by the time I joined the practice, my colleague was quite pleased for me to take on his care. It was all very hard. And not surprisingly, he had chronic pain from being virtually immobile. He was depressed, and he developed hypertension and ischemic heart disease. He was catheterized because it was too hard now to get to and from the loo. He'd had multiple visits to hospital with pseudo bowel obstruction and then bowel obstruction, so he had a colostomy. And he'd had a recent CVA and left-sided weakness. But one thing that was good for him was ACC covered his costs. So these visits were funded, so that was something. And they funded some of his medication and some of his personal care. It was rather sad. He lived alone. There was a family member, quite distant, elderly parents with whom he didn't have much contact. And the people who really saw most of him were his caregivers who came in to supervise his medication, and the St. John's ambulance people who regularly came and picked him up when he fell out of bed. He had been under the pain clinic at the hospital, and then our colleague, the anaesthetist who was running the pain clinic, retired. And this chap literally and metaphorically fell through the cracks many a time. So when I first saw him, these were his symptoms. And the ones that bothered him the most were painful muscle twitching and really the despair. He was feeling pretty hopeless about life. He had, not very long before I first met him, he'd lost his license. He'd been seen driving erratically down the middle of the road, and the police stopped him and his license was taken. And he was desperate to get it back. And that's another reason he came to me, not my colleague, because the colleague had said, nope, not doing that. And so he was trying to desperately to get this license back, but he was a real mess. So on examination, he was depressed looking. He had a bit of a tremor. He was dysarthric. He had some crackles in his lungs. He was edematous, so I think he was in some cardiac failure. He had a little bit of movement in the right leg. He could transfer from the bed to the chair and back. So it was quite hard going. These were his medications. So he's not the worst, not like your 30-something person, Jan, but I counted 15. So yeah, get your head around that lot.
It's probably 30 pills.
Yeah. So the first lot, the first bracket reflected the pain clinic. I think he'd been extensively rehabilitated at Burwood, and had extensive pain specialist management over years. So I didn't want to tamper too much with his pain medication. It had taken a long time to get him reasonably stable, I think. He'd had psychotic episodes, and he was under community mental health as well, hence the risperidone. Yes, any comments or thoughts?
How many minutes into the consultation are you now?
We always ran over, hugely. We just did. Sometimes my receptionist friend was kind and she gave me longer, and he wasn't charged extra because ACC funded his visit. So yeah. We could do that, yeah. And it was always prolonged for him, yeah.
Have you met anyone that's able to distinguish between the effect of the tramadol and the effect of the oxynorm and the oxycodone?
I think tramadol has a lot more side effects.
I'm sure.
Yeah.
But in terms of the desired effect, I've not met anyone that can.
No, in palliative care we would never generally use tramadol unless somebody was really stable on it. Yeah.
Why I ask is I've got a similar patient, and we're just broaching the issue with him, he's a younger man, about how does he know what he wants at the time.
Yeah.
And I think that's where the physician or the doctor has a role in doing no harm. And if you put too much in front of him, the choice is actually too hard for the patient.
Yeah. And this kind of patient was bouncing in and out of hospital a lot. He'd go through ED, and the opiates would go up and down, they'd change. There would be IV this and IV that, and it was a nightmare, really. That was happening quite a lot.
Was he allergic to morphine, I wonder?
No, I'm sure that morphine had been used initially. I think it would have been used.
Yeah.
Why did you say that?
Well, I mean, there's the prescribing from hospital doctors for oxy. And I thought, well, if the DPAC guidelines are for people allergic to morphine, how come we went wrong this path?
Yeah.
But
I think there's a lot of over-reporting of allergy to morphine, and I can honestly say I have yet to meet anyone who is truly allergic to morphine. And as with many drugs, patients will say they're allergic to something when what they've experienced is an adverse effect. And I see patients who will say to me in hospital, you know, oh, I can't have morphine, I'm allergic to it. And you look at their chart and they've been having it for the last week.
yeah,
And they've not even been aware that that's the painkiller they've been getting. So, yeah.
So I think morphine is the gold standard, particularly for cancer pain, but in certain populations, and it depends a lot on their renal function as well, morphine, they can get a lot more side effects, or significantly more side effects on morphine than, say, oxycodone or fentanyl, but it should be used very selectively, I think.
I mean, I work at Burwood Pain Clinic, and one of my comments would be, I mean, he's on slow release and quick release. And in chronic pain, I mean, one of the issues is that there's no concept of breakthrough pain. You have pain flare-ups. And so a lot of people have a palliative care model where you have a breakthrough pain in cancer, and people take short-acting medications more for distress. And so one could rationalise that, and then whether there is any benefit being on an opiate and tramadol is another issue. And then even further would be, why has he still got pain if he's on all these medications? Because we know that 70% of people don't get any pain relief from analgesic medications in chronic non-malignant pain. And so, I mean, those would be things you've got to consider.
Absolutely, yeah. And as we'll see, there's a very strong emotional pain here, the total pain, yeah.
Marion, what was his attitude to taking all of those?
Well, he was quite committed to taking them, I think, although it could be a bit erratic, and there were certainly demands for more oxynorm a lot of the time. So he liked the oxynorm. It gave him a bit of a high or a bit of a boost, I think. He was probably addicted to that, and he used it for a bit of escape, I think, honestly. Yeah, so being the clever GP that I am, I identified polypharmacy. And I wondered, working in palliative care, we sometimes see serotonergic syndrome where people get the myoclonic jerks and the sweating and so forth. So I wondered about that. That just sort of flitted through my mind and flitted out again. And I knew that we had a pharmacy facilitator in Wanganui who was keen or willing or able to do medication reviews for patients. And so I asked her if she would visit him at home and review his medication. And this was wonderful. She did. She spent significant time with him, and she's here with us today. And she was able to negotiate some changes with him. She also saw his house where he lived, which I hadn't done actually. And I think in one visit there was oxynorm scattered all over the carpet, and the dog had eaten some of it, and the dog slept for several days, and it was all a bit chaotic. But she managed to negotiate the stopping of the tramadol, which we identified as possibly causing some of the serotonergic syndrome, and the amitriptyline. And I saw him later, and things were improving for him a bit. He was still in cardiac failure, and I added some spironolactone, which might or might not have been beneficial. But I saw him later again. Serotonergic syndrome, just wanted to run that past you. That's just some of the symptoms, some of the features, and he had some of those. He did suffer quite a lot from sweating, but the opiates can do that too. And he had the hypertension. Those were the ones that he, and the Myclone. So subsequently, I saw him, and a few things had happened in between then. He'd been into hospital and come out again. His amitriptyline had been restarted by somebody who didn't realize it had been stopped. His heart failure medication had been changed around a bit, but the next time I saw him, he was heaps better. He was off the tramadol, he was off the amitriptyline, he was out of cardiac failure, and he was really pleased with the whole situation. He was desperate now to get his driving license back. That was what he wanted. And so I asked him, I said to him, what would you do if you got your license back? He had a hand-operated Mercedes. And he said, because I was a bit worried he might harm himself. That was always in the back of my mind, that he might harm himself with his car. And he said I would go camping. I just put a tent in the back and I'd go out with paraparas and I'd find a little spot and I'd camp. He said because before his accident that was the one thing he'd wanted to do. And crazy or not, I thought, well, this is worth striving for. And so I approached the Transport Safety Authority and they said, it's up to the doctor to decide whether he's capable of driving again. I said, oh, that's too hard. And they said, well, you could get a road test. That's $500, I think. Maybe it's gone up. So ACC agreed to fund a road test, and we managed to track down one of the two people in the North Island to do the road tests, and they agreed to test him. So I was really excited about this, and we were in this little bubble of sort of happiness for a little while, which was nice. But on the day of his test, he was too unwell. He was in hospital again, and it never happened. And very sadly, in December, he was found dead at home by the side of his bed. And it was sad. And I sometimes wondered if he had sat that test and failed, you know, things might have got a whole lot worse for him. So it was sad, but things were never going to work out well for him. So that's really a case of where the deprescribing was a success, but the patient died. That's the swampy lowland of general practice. That's what we're up against, isn't it? This is the reality. Yeah, so I was really concerned that it was oxymoron poisoning, but it wasn't. He had septicemia from a probable pyelonephritis. Yeah, which had probably been rumbling for a little while, and perhaps we hadn't picked it up. So that was sad, but at least it wasn't self-poisoning, which I was relieved about. Yeah. So I just put up the definition of palliative care. I'll let you read that. That's a bit of a sentence, isn't it? No punctuation. No breathing allowed.
God, basically.
So I want to tell a little hospice story with a happier ending. So this lady is fairly typical of patients that come to hospice. She had metastatic Cea colon and she had renal anemia, we thought, and she'd been bouncing in and out of hospital with partial bowel obstructions. And she had come into ED and she was hyponatremic, once again in pain with nausea, constipation, breathless, dizzy, anxious. And she just wanted to feel better. She didn't want any active intervention. She was beyond invasive treatments. And she lived alone, but she had a very supportive family who were around her a lot and really helped her at home. So she's fairly typical of some of our elderly hospice patients. That's her medication list. And I can hear you thinking, well, that's not polypharmacy, really. Well, it's 6. But it's not so much about the numbers, is it? As we heard, it's more about the combination. So in this old lady, with her EGFR of less than 30, morphine wouldn't be the drug of choice first up for her pain management. I think we all agree on that. It was probably contributing to her nausea, constipation, drowsiness. Interestingly, somewhere along the line, she'd been prescribed the prochlorperazine. I think she might have talked about dizziness and vertigo, and that was kind of thrown into the mix somewhere along the line. I wasn't sure where that came from. Ondansetron is a real favorite of EDs. They like that. It's relatively expensive. At least we don't have to get special authority anymore, but it's constipating in the elderly. Well, constipating in anybody. It's not first line for nausea palliative care. Then good old lactulose. Apparently, I haven't tried it myself, but it's quite unpleasant to take, especially in elderly people, lots of wind and bloating. And there's my favorite, omeprazole there, in a good whopping dose, and she's hyponatremic. And PRN, morphine for breakthrough pain. So we looked at that list and scratched our heads and thought, well, what should we do? And so we took the palliative approach, and I'd be interested to hear from my Burwood colleague if this would be your approach. So we switched her from Eslon to fentanyl because of the renal impairment, and also just reduced her burden of having to swallow tablets. We used fentanyl drops. We used the injectable fentanyl in an oral, just in a syringe under the tongue for breakthrough pain. It's quick acting, but it's short lasting, and that was just to get her through the initial settling in period with the fentanyl patch on. So she was on 20 milligrams in 24 hours of Myclone, and that equates to 12.5 microgram per hour patch. And we stopped the prochlorperazine because we thought it was probably contributing to her symptoms. We stopped the ondansetron and the lactulose, and we reduced the omeprazole. And so we used the fentanyl analgesia. For an antiemetic, we used haloperidol, which is really good, broad-spectrum antiemetic for opiate-induced nausea. And we instituted some midazolam for her anxiety, either the nasal spray or subcut. Palmerston North pioneered the midazolam nasal spray for breathlessness, really, in palliative care. Although they've done a huge piece of work recently where they've debunked their original theory, and they say it's no longer any more effective than placebo for breathlessness, but they say it's good for the anxiety of breathlessness. So we still use it for the anxiety of breathlessness. But opiates are the first line for breathlessness in palliative care. And dose is important. The respiratory physicians tolerate us using up to 30 milligrams in 24 hours of morphine for breathlessness in palliative care, and sometimes people tolerate more than that. And we got her bowels working again with some Blacksol. And I haven't included it in there, but we looked at her psychosocial and spiritual needs. So she had the chaplain visiting, she had the social worker visiting, and her biggest anxiety was being a burden to her family. And we had a lovely family meeting where the family were able to say, you're not a burden, you're a treasure, we want to look after you at home. You know, that's what we're all about. And so it was a good outcome. Her pain settled, her bowels started working, her other symptoms improved, and she began eating and drinking again, and her renal function improved, and she was able to get home to be cared for by her family for a bit longer. And so it was a real improvement in quality of life for her, which was what it was all about. With a little, not so much deprescribing as represcribing, you would say. So that's possibly that appropriate prescribing. And that's very much what we do in hospice, is just fine-tuning the medication, I think, trying to see what's causing what and shift it around a bit. And I guess we're lucky we have time. You know, we have at least an hour per patient and longer on any one day to do that kind of thing. And we can keep them in and observe the changes and monitor their bloods and so forth. So that's the beauty of hospice care. So that's my approach, which I think is pretty similar to Ian's approach. It's very much about the individual patient and their situation, including their bloods, their renal and hepatic function. And I've just scribbled in here, and consider prognosis, because I think that's really important, and I think we have to factor that in. Somebody talked about ACP, and yes, you know, I was on the working party in Wanganui for ACP, and I was a real champion of it, and I find it incredibly difficult. The first time I tried to do an advanced care plan in general practice, I had a bit of time. Somebody hadn't turned up, and I had an elderly lady in her 80s there who was living alone in a great big house. And I said to her, so you're alone and your family are all distant and you're in this big house with quite a big garden. How are you feeling about the future? I was trying to do the sort of open-ended thing. And she looked at me, she said, I'm very glad you asked that, doctor. I'm thinking of taking up embroidery, she said. That's as far as we got. I never got complete failure. Yeah. I find it very hard, you know, asking those questions in general practice. People don't really want to go there. I had a chap last week with asbestosis, COPD, cardiac failure, and he had just been turned down for a knee replacement. And I tried to do that sort of advanced care planning thing, saying, how are you feeling about the future? And he said, I'm going to struggle on, I'm going to fight. You're not going to get me at your hospice, he said. So, okay. So I find it really hard. As Ian said, you can be vilified for trying to go there until you have to. So it's about discussing their medications and negotiating the deprescribing. And it can be very challenging. You know, even in hospice, people don't want to part with their statins. Some doctors started and told them they had to be on it, and they're very loyal to their doctors. That's wonderful, but yeah, it's really difficult. Even talking about death and dying in the hospice is very, very challenging. Yeah, so I think the documenting and communicating is one of the key messages, really, is letting everyone else who deals with this patient know, and hopefully they'll read the letters. And and reviewing and monitoring. So this is where you're not going to turn over the page. Oh no, you can turn over the page in this one. So that's the conclusion. I think polypharmacy is here to stay. It's inevitable given the patients we look after and their longevity. They're walking miracles, at least for the next 20 years. And then I think the baby boom starts to tail off again, and maybe it'll all be different and everybody will be on specially tailored biologicals or something, I'm not sure. So we try and prescribe to the individual patient their needs and wishes, and really paying attention to detail. And in hospice we say, why has this patient got this symptom at this time? What is it about this patient this time, this symptom? And try to hone in on what it is that's causing that. And then monitoring, communicating, and documenting. Right, this is where you're not turning the page, okay? Chocolate fish for anybody. So if you've read the answer already, please don't shout out. So I always ask the trainee interns at hospice, I ask them this question. I get wonderful answers. Midazolam, morphine, Floxidrops, Floxamillion, Cloxidrops, oh yeah.
Is it like communication or encouragement?
Good one, yep, good one. So there are three parts to this question. There's the answer, there's who said it, and there's the where it was written, who wrote it, and where it was written. So, very good. He's getting a fish. And pass him around. So it was Abraham Verghese, who's a physician in the States. He got a Fulbright scholarship to study medical humanities. And he's written some wonderful novels about medicine. One's set in Ethiopia and one's set in the US. And I really think that this is a reminder that as practitioners, we bring ourselves to the relationship, and we can be highly therapeutic, sometimes more powerful than the medication. And it's our care, attention, and interest and empathy that patients want. If you ask patients, and particularly in palliative care, if you ask patients what they want, it's the interest, the empathy of the carers. We should never underestimate the power of our presence, and it's this holistic approach, including the psychosocial and spiritual, which is the essence of palliative care. And I think it can be applied to other settings. I think it's the question to the patient, what matters most to you? And then going with that. So, thank you very much. I'm hoping there are no questions at all.
Just about 5 minutes before the invitation, I just find when we're talking about people who make changes, especially Marion saying palliative care, you make changes and then the patient comes back and they can't remember. I find it very useful to give them a list of all the medications that they have each time they come and update that list and underline what's been changed, just so they have it there. I know hospital doctors can sometimes access our list, but it's for the patient who has it.
Yes, at hospice we give them a medication card and we continuously update that, yeah. And hopefully they bring their updated version to you, yeah. Yeah.